So let's see. So what is the rules of this quiz? Rules of the quiz is that everybody, I'll be giving you 20 seconds to answer the question. Read the question well and then answer it, okay? And then we will discuss it, okay? So I'll read the question for you and then I'll give you 20 seconds. Perfect, okay? So this is a 69-year-old woman who had transient ischemic attack for the past 3 months. She died and on autopsy, aorta showed some plaque. Okay, the curated erythematous plaque has grossly yellow tan appearance. Microscopically, which of the following material can be found in abundance in the form of crystals within the cleft-like spaces? So the options are cholesterol, hemosiderin, triglyceride and lipofuscin. So look at the image and answer. So it should be fastest fingers first. You should answer the first. So whoever answers the first and all the answers correctly will be the winner. And I will choose the prize later. What prize I have to give, that I will choose later. But for now, you have to answer. So the time starts now. So 20 seconds for you. Quickly answer. What do you think is present in these crystals? So let's see how you are answering. So you should answer fast. Okay, let's see. Okay, so what is it? Yes, so what is the answer? What is the answer to this question? Of course, it is, what is it? It is cholesterol. It is cholesterol. Why is it like cleft-like spaces? So always remember, when we talk about fat, fat can accumulate in 3 forms in our body. Okay, first either as triglyceride or as cholesterol or as phospholipids Okay, so accumulation of triglyceride is called as steatosis. Accumulation of triglyceride is called as steatosis. Accumulation of cholesterol. Now, you know, cholesterol is a very toxic substance. It is a very toxic substance. So normally it should not accumulate. Okay. So cholesterol, when it accumulates, it can accumulate at 3 places. It can accumulate at 3 places. So let us see. So when we talk about cholesterol, so cholesterol can accumulate in 3 places. Okay, either on the blood vessels when it is called as atherosclerosis, or it can accumulate in the gallbladder. Okay, so when it accumulates in the gallbladder, what is this called as? Cholesterolosis. This is called as cholesterolosis. Or it can accumulate in the subcutaneous tissues or tendon sheaths, and then it is called as xanthomas. Now, when we talk about the blood vessels, so normally you all know blood vessel is lined by endothelium, isn't it? Now, you all know that when I talk about endothelium doesn't like anybody to stick to it. So nothing should stick to the endothelium. So if the cholesterol, okay, if the cholesterol is coming and sitting over the endothelium, that means that there is some dysfunction in the endothelium. Therefore, the hallmark of atherosclerosis is endothelial dysfunction. So what is the hallmark of atherosclerosis? Endothelial dysfunction. Okay, endothelial dysfunction. So dysfunction can be very mild, simple dysfunction, or it can even be endothelial damage. But that's the hallmark of atherosclerosis. So whenever the endothelium is dysfunctional, the cholesterol will come and sit over it. Okay, cholesterol will come and sit over it. Now, you know what will happen? So our macrophages will get activated to eat it up. So quickly the macrophages will come and they will start eating up this cholesterol. So these macrophages which eat up cholesterol are called, they will change into foam cells. They will change into foam cells. And where are they sitting? This all changes occurring over the endothelium. So what is this topmost layer of the blood vessel called? Intima. So can I say over the intima a flat layer of foam cells can be deposited. So this is very flat, that is, it doesn't obstruct the lumen, it doesn't cause any problem. So this is called as a fatty streak. What is this called as? A fatty streak. But, and one more question, what age does fatty streak start? Do you know that? Infancy. It starts at 1 year of age. Okay, so if somebody has endothelial dysfunction, it can be very early in the life. So this fatty streaks can start even in 1 year of age. You understand that? And after that, you know, all our acquired habits, okay, sedentary lifestyles and all the bad dietary habits, okay, and then hypertension, diabetes, all that happens, and this will keep on growing. So with time, what will happen? So this fatty streak, which was a flat lesion, now more and more lipid, more and more cholesterol will come and deposit over the endothelium. Now what will happen? So now the number of macrophages are not enough to eat so much cholesterol. So what will happen now? So all of you know, blood vessel has 3 layers: intima, media and adventitia. And this flat lesion is depositing here. That is, foamy cells are already formed in the intima as a flattened lesion, as this is a flat lesion and this is over the endothelium. Okay, now what will happen? Now the smooth muscle cells from the media will also want to help. Okay, so this smooth muscle cells from media will also start shifting into the intima. So what will happen? So with time, this lesion, which was a flat lesion, will start growing. It will start growing and it will change into erythematous plaque. It will change into erythematous plaque. Okay, so erythematous plaque now has 2 types of foam cells. What type of foam cells? One, the macrophages, and other, the smooth muscle cells, which are now eating up fat. Okay, so remember, there is no difference between it. So somebody asks you what all can become foam cell. So it can either be a macrophage or it can be a smooth muscle cell. Both can become a foam cell, but still the amount of lipid is huge. Okay, so then some of the lipid can remain inside only. Okay, that is, although the macrophages and smooth muscle cells are eating up and changing into foam cells, still some of the lipid can remain like that also. And this lipids usually are present in the core. So this is all extra lipid that is present in the plaque. So can I say that in plaque we have 2 types of lipid, extracellular lipid also and intracellular lipid also? So extracellular is outside, intracellular is present within the macrophages. So now, so this is core. So later on you will study that a plaque has it has a cap also, it has a shoulder also, it has a core also, and that and all we study in blood vessels. But for now, what have you read? That there is 2 types of lipid here, extracellular and intracellular. And what is this lipid? Cholesterol. Okay, now when we study fat has a problem, you know what? So ideally, whenever you suspect a fatty tissue, you shouldn't put it in formalin. Why? Because formalin washes off all the fat. So what should you do? You should always try to see fat in a fresh state. What do you mean by fresh state? Frozen section. Fresh means frozen section. You should try to see it in the frozen section. So when you see it in a frozen section, then it will be seen well. But if you put it in formalin, then it will be washed off. So intracellular cholesterol is already there as foam cell, so nothing happens to it. But what happens to this extracellular cholesterol? So when this is washed off, this leaves random clefts. This leaves random clefts. So this appears like this. Can you see this? It appears like this, random clefts. So this is what random clefts are appearing. And what is present in this random cleft if somebody asks you? Cholesterol. So our body treats this cholesterol as a foreign body. So who comes to eat it also? Macrophages. They try to eat it, but sometimes they change into giant cells. So sometimes in a plaque you will also be seeing giant cells. Which kind of giant cells they are? They are foreign body giant cells. They are foreign body giant cells. So that can also be seen in a plaque. You understand that? So these crystals are cholesterol crystals. They are cholesterol crystals. Okay, let's look at the other options. Hemosiderin, triglyceride, lipofuscin. This triglyceride is also a fat. So whenever you see clear spaces, that gives you an idea that it is fat. So I've already told you, accumulation of triglyceride is called steatosis, and we have steatosis either in the liver or in the heart. Okay, majoritarily it can occur in other organs also, but liver and heart. In liver, it can be either as macrovesicular steatosis and microvesicular steatosis. So remember, how does a steatosis appear? See that also, so that you don't confuse in the exam. Okay, so this is how steatosis appear. That is, as soon as you put that tissue in formalin, it will wash off. So, but it will be inside the cells. So you can see well-defined cells, and then nucleus is the key. Nucleus will be at the periphery. Plus, please remember, nucleus is never indented by the fat. Okay, so fat never indents the nucleus. Nucleus will be round, and fat will be present here. Big fat will be present here, which due to which the nucleus is pushed to the periphery, but it is not indented. So this type of steatosis is called as macrovesicular steatosis. Macrovesicular steatosis. Okay, and in contrast, look at this steatosis. What is this? So here the nucleus is always in the center, and there are small lipid vacuoles all around. So what is this? Microvesicular steatosis. This is microvesicular steatosis. Okay, so macro and micro. So key is nucleus. Nucleus in the center with small vacuoles every around, microvesicular. Nucleus in the periphery with big fat vacuole, macrovesicular steatosis. Okay, so that is steatosis. And I told you third point also, that this can accumulate as phospholipid. So phospholipid accumulation, okay, is called as myelin figure. What is it called as? Myelin figure. So accumulation of phospholipid is called as myelin figure. So what is myelin figure? So myelin figures are formed whenever there is damage to the phospholipids, and these phospholipids are usually damaged in cell injury. So remember, irreversible injury has more number of myelin figures than reversible, but in reversible also myelin figures can be seen. And when they fall off, they form the whorls. So let us see how these whorls appear like this. So these whorls you have to see on electron microscopy. So whorls seen on electron microscopy, myelin figures. So remember, somebody asked you, what are the whorls in pathology? Quickly. So who's going to answer? Quick. Who's going to answer? Whorls in pathology. Quick. What is it? Yes, it can be either myelin figure, or it can be either Samoma bodies. So what was Samoma body? I hope you remember. What was it? Dystrophic calcification. Okay, it's seen in the papillary carcinomas, meningiomas, prolactinomas. Okay, or it can be as I hope you remember this, keratin pearl. So what is keratin pearl? There is a keratin in the center, and around that malignant cells are arranged. Where do you see that? Well differentiated squamous cell carcinoma. So these are the whorls. So on electron microscopy, myelin figure. Normally if it is calcium always gives a purple color, okay, violet color on HND. So when you see violet color deposits, and they are also concentrically arranged, it is as if you have cut a tree. So well defined, concentrically arranged. And keratin pearl is that center has a keratin and cells are arranged around it. Okay, so that's whorls. Okay, so now spotter for you. You're going to identify. Okay, so what is this? What is this? What do you think is this? Is this very clear, or is it foamy? It is very foamy, isn't it? It's very foamy. So this is not clear. So these are what are called as foam cells. What are these called as? Foam cells. Okay, so I just now told you, if they are present in the vessel wall, think of atherosclerosis, but they can be present in the gallbladder also. And then what is it called as? Cholesterolosis. What is it called as? Cholesterolosis. So these foam cells are usually accumulating where? In the lamina propria of the gallbladder. They accumulate in the lamina propria of the gallbladder. And you can see this grossly also. Okay, so when a surgeon does cholecystectomy, what does he see? He sees that normally the gallbladder mucosa is green colored, okay, because of bile. Okay, so that in that green color you can see yellow colored dots, yellow colored specks. So these yellow colored specks on a green color gallbladder gives a very classical appearance called as strawberry gallbladder. What is this called as? Strawberry gallbladder, like this, like strawberries. Can you see this yellow specks on a red background? But it can be green background also, isn't it? Red background, why? Because sometimes, you know, it is blood stained. So that is why. So it gives a very typical appearance like a strawberry gallbladder. Let's see the real gallbladder. Can you see this? So what is this gallbladder? Strawberry gallbladder, which is called as cholesterolosis. Okay. So remember, cholesterolosis is accumulation of cholesterol in the lamina propria of gallbladder. So 3 ways of cholesterol accumulation. It is triglyceride, phospholipids and cholesterol. So everybody to remember now here itself, just quickly, stains on fat. So remember, ideally the fat should be stained fresh, and if you stain it fresh, the stain used is oil red O. So best stain for fat is oil red O. But if you fix it, then what will happen? All the fat will be washed. So then you should use a black color stain. What stain? Sudan black. Sudan black is for fixed fat. Fresh fat uses is best come with oil red O. So remember, if you fix the fatty tissue, oil red O's positivity doesn't come. Oil red doesn't take up stains. Okay. So oil red O only on fresh specimen, that is frozen sections. Okay. So is everybody clear with this question? Yes. So the question was simple. Okay. But you should be able to identify this. So the answer here is cholesterol. Of course, hemosiderin is never like this. Hemosiderin is always a golden brown color deposits. So this doesn't appear like this. Lipofuscin is always a perinuclear deposit, and it is also yellow brown in color. So it's out. Okay, let's go to the next question. Okay, so you have 20 seconds to answer this question. Okay, so true about downy cell is they are CD8 lymphocytes with ballerina skirt appearance. They are B lymphocytes with ballerina skirt appearance. B lymphocytes are increased in number. Cyclin D is decreased in this condition. Yes. So let's see how many of you answer it. Let me check. Okay, let's see how many of you are answering it correctly. Okay. Okay. You should answer also, guys. Seeing the question, you should start answering, like answer 2 is this, answer 1 is this. Okay, so I have to search who is answering on YouTube, who is answering on Facebook. So please answer. Okay, write the question number and then answer, so that I can choose the winners at least. Okay, so okay, so let's see. So what is true about downy cells? So what are downy cells? Where do you see them? Where do you see them? Very good. Epstein-Barr virus infection. Epstein-Barr virus infection. So, what are they? To understand this, you should understand that which are the cells which are infected by Epstein-Barr virus. So, remember, Epstein-Barr virus usually infects B cells. Usually infect B cells. Why? Why does it infect B cells? Because B cells have a receptor called as complement receptor 2, or which is identified by CD21, which is identified by CD21. So Epstein-Barr virus enters into the B cell through receptor called complement receptor 2, okay, which is on B cells. So that is why they enter into B cells. So when they enter into B cells, they start causing proliferation of B cells. How? Because as soon as B cells enter, they induce some genes. Like LMP1, like EBNA2, like viral interleukin 10. So I hope you remember LMP1. What does LMP1 do? It activates the signal transduction pathways. Okay, so it can activate NF-kappa B pathway, or it can activate the JAK-STAT pathway and start causing proliferation. What does EBNA2 do? It quickly activates the cyclin D. I hope you know what is cyclin D1. It is the cell cycle initiator. It initiates the cell cycle. So whatever happens by both of them, immediately the proliferation of B cells is going to start. So B cells are going to proliferate very rapidly. What is this viral interleukin 10? I hope you remember, interleukin 10 is an anti-inflammatory interleukin. So this is going to suppress the inflammation so that virus can escape. Okay, so nobody can kill it and it can quickly move in the body and escape. Okay, so this is causing massive B cell proliferation, and it is escaping inflammatory cells also because it's suppressing them. So now who can kill it? Who can kill it? So you know who is the brother of B cell? T cells. Okay, so who is the king of immune system? T cells. So normally T cells are the kings and they are predominant, they are more in number, they are strong. And what do they see? They see what is happening to my younger brother B cell. Normally his number is not in so much. Why is it proliferating so much? Okay, so have you seen that Gladiator movie? So what is typical in that Gladiator movie? Those fighters, no, those who are going to fight, they wear that skirt like dress and come, isn't it? So now T cells is saying something is very wrong with B cell and I have to cure him. Okay, so they call the killer B cells, killer T cells. Who is the killer T cells? Cytotoxic. Name itself is saying cytotoxic. That is very toxic to the cells, kills the cell. So CD8 is basically meant to target the cells when they are infected by viruses, okay, or cancers. So to kill the cells. So these CD8 cells are called, see B cells are having problem, you have to do something. So these CD8 cells say no problem, I will wear that gladiator dress and attack the B cells. So same thing happens. So CD8 cells change, okay, from their normal shape into activated cells. They change into activated cells, and when they change, they wear that skirt. So what is this skirt? Ballerina skirt. What is this skirt called? Ballerina skirt. Why is it called ballerina skirt? Because it is like ballet dancers. So if you see ballet dancer girls, they also wear like this, dress like this. So I'm just giving you example of gladiator because they are fighters. They're going to fight now. So actually it is a skirt which resembles a ballet dancer. Okay, so because it is very curvy. It is very curvy. Okay, so the cytoplasm. So okay, the cytoplasm of T cells, cytotoxic T cells becomes like this, very curvy. And how, if you're having any doubt how that is it really curvy, how to pick it up? See, red blood cells fit into these curves. Okay, red blood cells fit into these curves, so you can see them. So let's see them. Okay, let's really see them. So can you see the cell? So what do you see? What do you see? So this is a lymphocyte, and can you see the outlines are very, very curvy. Outlines are very, very curvy. And how do you confirm it's curvy? Can you see red cells fitting into these curves? So these are really downy cells. These are really downy cells. And who are downy cells? B cells or T cells? Obviously CD8 T cells. So these CD8 cells want to kill the B cells. So obviously whose number will be more? B cells or T cells? T cell number will become more. So these T cells are going to attack the B cells. So let us see them quickly. Now read this question. So these are CD8 lymphocytes with ballerina skirt. That's true. These are B lymphocytes with ballerina skirt. That is wrong. B lymphocytes are increased. No, T lymphocytes are increased. So this is also wrong. Cyclin D is decreased. No, just now we studied, no. So EBNA gene typically increases the levels of cyclin D so that more cell proliferation continues. So the levels of this is increased. So the answer is A. So how many of you marked A? Give 1 point to yourself. Okay, and anybody who marks any other option, give -1 to yourself. Okay, so -1 and +1 is the rule of this game. Okay, so -1 and +1. So I'm going to ask your scores afterwards. Okay, same, give score for the first question also. So first was a googly question, but okay, second one +1 and -1. Okay, let's come to the third question. Okay, so let's come to this. Okay, so question is true about autophagy. So read the question well and then answer. True about autophagy. Becklin 1 decreases in autophagy. mTOR stimulates autophagy. Lysosome forms invagination and starts autophagy in macroautophagy. Autophagy is deranged in herpes simplex virus. Yes, what do you think is the answer? So, 20 seconds to you to think. Let me see how many of you are answering. Okay, so yes, so what is the answer that you marked? What do you think is the answer? So what is the answer? Okay, let's see, first understand it. Okay, so when we talk about autophagy, what is autophagy? Autophagy is cell eating. Okay, cell eating its own cytoplasmic organelles to derive energy. Autophagy, eating yourself. Okay, so autophagy is a procedure in our body which basically our body does to eat up some waste organelles or some organelles so that it can derive the energy. So whenever our body needs lot of energy, it starts eating its own organelles. Okay, so first thing you should remember is that when will autophagy occur? See, autophagy usually occurs whenever our body feels that these organelles are waste, so they should be discarded, or whenever the body is very poor in resources, So it's saying I need energy, so I should eat up my own organelles. Okay, so now first point you should remember, what is this mTOR? So mTOR is a molecule which gives a sense of well-being. It is a molecule which is produced whenever there is a proliferation going on. Okay, so it increases the sizes of the cell, it stimulates it shows that proliferation is occurring, size is increasing. See, it is like one is rich and one is poor. So whenever you are rich, your size increases, you flaunt. Whenever you are poor, you say, oh, I don't even have food to eat, give me something to eat. So autophagy occurs whenever you are at a very poor state, cell is at a poor state. But mTOR shows you that your body is in a very good state. So can I say mTOR and autophagy are inversely related? So mTOR will inhibit autophagy, or autophagy will start when mTOR is not there. You understand? So mTOR and autophagy are inversely related. Okay, and this was, I think, JIPMA question 2 years back, and they were both options were there, and everybody was confused. mTOR is also related to autophagy and Becklin also. What should we mark? So please remember, mTOR is inversely related to autophagy. In fact, they inhibit. mTOR inhibits autophagy, or autophagy if it occurring, mTOR will not be there. So mTOR does not stimulate autophagy. This is totally wrong. Okay, so second option is wrong. Now we left with 3, 1, 3 and 4. Now, who starts autophagy? So it is a molecule called as Becklin 1 which starts autophagy. So autophagy is started by a molecule called as Becklin 1. So which is the molecule which initiates autophagy? Becklin 1 initiates. So the option here that is given is Becklin 1 decreases autophagy. Absolutely wrong. Becklin 1 initiates autophagy. So it starts autophagy. It doesn't decrease it. It starts autophagy. So this is also a wrong option. Now let's come to the third. Lysosomes form invagination and starts autophagy in macroautophagy. What is this macroautophagy? What is autophagy? So actually we have 3 types of autophagy. So very good diagram. Okay. So this diagram I have taken from a book, Rubin. So remember, when I talk about autophagy, there are 3 types of autophagies: macroautophagy, microautophagy and chaperone mediated autophagy. So macro, micro and chaperone associated. Okay, so difference you understand, very simple. It's a very simple difference. See, in macro means big. So in macroautophagy means there is a special phagophore that is formed. So big phagophore molecule is formed like this. Phagophore molecule is formed, and this will form and eat up all the organelles. So it will eat up all the organelles, and once it eats up all the organelles, this is locked. Okay, it forms a phagosome. Okay, So who initiates this formation? So this molecule which initiates this formation is called Becklin 1. Who initiates it? Becklin 1. And who locks this? Okay, so once the phagosome is formed, the ends are locked. So it's like this, it is extended and the ends are locked by a molecule called LC3. What is LC3? Light chain 3. What is LC3? It's a microtubule associated protein, so which helps in elongating the ends and locking them up. So this is a microtubule associated light chain 3. So this locks it and forms the phagosome. So it is said that whenever LC3 levels are increased in our body, whenever LC3 levels are increased in the body, it is a very, very strong trigger that your body is undergoing autophagy. So what is the marker of autophagy that we use? LC3. So LC3 is the marker of autophagy. So once this phagosome is formed, this phagosome is fused with lysosome. This phagosome is fused with lysosome. So see here, phagosome is fusing with lysosome, and these two fuse together and to form phagolysosome, and killing starts occurring in the phagolysosome. Okay, so this phenomena is called as macroautophagy. What is this phenomena called as? Macroautophagy. Then we have microautophagy. What do you mean by microautophagy? In microautophagy, what happens is lysosome itself. So lysosome itself forms an invagination. Can you see, this is a lysosome and it is forming an invagination. So lysosome itself forms an invagination and starts eating the organelle. Okay, it starts eating the organelle. Okay, so there is nothing has to be done. This is eaten up and then the lysosome breaks it. So what is this called? Microautophagy. Even lysosome itself forms an invagination and eats. Okay, and the third is chaperone mediated autophagy. What do you mean by chaperone mediated autophagy? Now this is very important, especially when there are misfolded proteins. So whenever our body has misfolded proteins which have accumulated. So I hope you remember which are the molecules which help in proper folding of the protein? Chaperones. So immediately, as if there is a misfolded proteins, chaperones will come and bind with it. Chaperones will come and bind with it. So these chaperones will be binding with these proteins. So there is a receptor on the lysosome known as LAMP2A. What is the receptor name? LAMP2A. Remember this receptor. So what is the receptor present on the lysosome? LAMP2A. This LAMP2A receptor is meant to identify these chaperone coded proteins, chaperone tangled proteins. All the proteins which are tagged with these chaperones can be identified by this molecule. What is this molecule? LAMP2A. Now what will happen is this LAMP2A will bind with chaperone mediated protein. So this protein will be inserted inside the lysosome and another chaperone will bind with it. So this chaperone which binds with it inside is called as receptor chaperone. What is this called as? Receptor chaperone. So this will hold the protein. It will hold the protein. And what will happen? This the chaperone which is bringing the protein, it will become free for binding with another misfolded protein, and this will go. This will become a free chaperone and it will go. And now this chaperone mediated protein will be digested by the lysosome. It will be digested by the lysosome. So this kind of autophagy is called as chaperone mediated autophagy. So are you clear with the three types? So whenever the phagophore is formed, it is macro. Whenever just lysosome forms an invagination, micro. And whenever chaperone brings it and it is identified with the receptors which endocytosis degraded, this is called chaperone mediated autophagy. So remember, what was the question? Lysosomes forms an invagination and starts autophagy in macroautophagy? No, this is microautophagy, not macroautophagy. So this is also wrong. Now, coming to where do you see autophagy? Which are the conditions where you see autophagy? So remember, autophagy is typically seen in three major conditions. Okay, so it is typically seen in three major conditions. So let's understand that three major conditions where it is seen is, number one, let me enlarge it first, neurodegenerative disorders. It is seen in neurodegenerative disorders. Okay. Number two, infections. Now here what you have to remember first is that there are certain genes. Okay, these are autophagy related genes which maintain autophagy, okay, which maintain autophagy, okay. So now there are certain infections and inflammatory bowel diseases, okay, and cancers, okay, which can alter these genes, ATG genes. They can be altered by these, and then it can cause a problem. Now there are some infections which everybody should remember. First infection is HSV. You know what does HSV does? What does it do? It goes and block Becklin 1. It goes and block Becklin 1. So what will happen if Becklin 1 is blocked? What will happen? Automatically the autophagy will not occur, isn't it? Why autophagy is stopped? So that virus is inside the cell and it can immediately cause damage and proliferation, so that it is not eaten up. So HSV virus blocks autophagy so that it is not killed. How does it block autophagy? By blocking Becklin 1. That's the target. So HSV blocks Becklin 1 and stops the autophagy. The second organism is TB. Okay. So TB causes alteration of gene ATG5. It causes alteration of gene ATG5. It can alter other genes also, but this is one common one which has recently come up. So it alters the gene, and so that digestion or killing of TB bacilli does not occur. There is one more which they have suggested, that is Shigella. Okay, so Shigella can also block autophagy. So HSV, TB and Shigella can block autophagy. In inflammatory bowel diseases, okay, like in Crohn's disease and ulcerative colitis, especially in Crohn's disease, they have said that there is an alteration of again ATG. Okay, so ATGs are alterated in this, ATG16 basically, A16L2, that's the exact gene, which is alterated in Crohn's disease. And cancers also can escape the killing by blocking the autophagy. So remember, so these are the conditions where the autophagy is affected. So remember this. So the option was autophagy is deranged in HSV. True or false? Yes, it's true. It's deranged because it blocks Becklin 1. That is why it deranges HSV. So how many of you marked it correctly? How many of you marked it correctly? Let me see. So how many of you went and answered it correctly? Okay. So if you answered it correctly, give +1 marks for you. If you answered wrongly, give -1 marks to you, because I'm going to ask you scores later on. Okay. Okay. Now let's go to the next question. Okay. So the next question is, which is not a peripheral immune tolerance? Which is not a peripheral immune tolerance mechanism? T regulatory cells, energy, apoptosis, or negative selection. So which is not a peripheral immune tolerance? So if you know it, you'll answer it quickly. So what's the answer? What is the answer? The answer is D. Negative selection is a central tolerance mechanism. So remember, we have two types of tolerance, central tolerance and peripheral tolerance. Central means that when the bone marrow, when the central cells itself removes all the self-reactive lymphocyte, that is central tolerance. So can I say the central tolerance occurs in central organs like thymus, bone marrow, lymph nodes? These are the central organs where the central tolerance takes place. And peripheral is day to day, okay, every time, daily, when the lymphocytes are circulating, how do they maintain the tolerance? That is peripheral tolerance. So in thymus, we have a gene called as autoimmune regulator. So name itself says, see, autoimmune regulator, okay, autoimmune regulator. So what is the work of autoimmune regulator gene? To cause negative selection. What do you mean by negative selection? All the self-reactive lymphocytes are removed. All the self-reactive lymphocytes are removed in the thymus itself. So this is negative selection. So what will happen if IRE is not working, this gene is not working, then what will happen? So negative selection will not occur. All the self-reactive lymphocytes will start coming into the blood and cause autoimmune diseases. So it causes autoimmune polyendocrinopathy. It causes autoimmune polyendocrinopathy. So this is very, very important for negative selection in the central tolerance. Okay, same thing is done in B lymphocyte. So this was about T lymphocyte. In B lymphocyte, what happens? The receptor editing occurs. Okay, so the receptor is edited so that they can no longer identify the self antigens. Okay, so that is receptor editing. But when we talk about peripheral tolerance, so peripheral tolerance occurs in 3 forms. Okay, so that occurs in 3 levels. So first peripheral tolerance is T regulatory cells. First is T regulatory cells. Second is apoptosis. Second is apoptosis. The third, okay, is energy. Okay, so T regulatory cells. What are T regulatory cells? They are a subset of CD4 positive cells which can suppress the inflammation. So these are specialized cells which can suppress the inflammation. Okay, and how do you identify that? So these T regulatory cells are CD4 positive cells, but they have a very special receptor on them. Okay, so T regulatory cells have a receptor on them called as interleukin 2 receptor. So which receptor is present on them? Interleukin 2 receptor. Therefore, we can identify them with a CD marker which can identify the interleukin 2 receptor. So which is a CD marker which identifies interleukin 2 receptor? It is CD25. So they can be identified by CD25, or they can also be identified by another marker called as FOXP3, which is very important molecule for them. So T regulatory cells are usually identified by CD25 and FOXP3. So they are actually meant to cause tolerance, peripheral immune tolerance. So when they feel that this antigen could be a self antigen, they just tell T cells to get suppressed. No need for reaction. So they are like priests who will say no need for fighting. Come on, so let's get silenced. That is T regulatory cells. But who takes advantages of them? Who take advantages of them? So who take advantages of them? Bad people who will come and say, who will come and manipulate the priest and say, no priest, you are so good, you are only going to help us, nobody else can help us, please help us. So who is this people? Who are these manipulators? Cancer cells. So what do cancer cells do? They will come and they will say to T regulatory cells, only now you can help us, sir, please come and help us. So what will these cancer cells do? Cancer cells will stimulate T regulatory cells. So what will T regulatory cells do in the effect of cancer cells? So they will suppress the immunity. So what will happen? Cancer cells will be very happy and they will start infiltrating. Do you understand that? So remember, T regulatory cells are normally meant for our peripheral immune tolerance, but cancer cells can increase the level of T regulatory cells and escape immunity. You understand that? Okay. So suppose if FOXP3 is mutated, okay, if FOXP3 is mutated or T regulatory cells is mutated, so especially FOXP3, if it is mutated, what will happen? So if FOXP3 is mutated, this will result in autoimmune diseases, obviously, because there will be even a small and the self antigen will come, there will be nobody to silence it, and our body will start causing autoimmune disease. So this causes a syndrome called as IPEX. What is the syndrome? Called IPEX. So what is IPEX? I'll give you next question on this. Think about it. What is IPEX? So IPEX occurs because of mutation of FOXP3. Okay. What about apoptosis? Apoptosis is another mechanism of peripheral immune tolerance. So whenever our body feels that no, this cell shouldn't be there, it's not good, we have to tolerate this. So it causes apoptosis by FAS ligand pathway. So how does it cause apoptosis? By FAS, it releases FAS, which goes and binds with FAS ligands, go and bind with FAS receptors, and they cause apoptosis. I hope you remember extrinsic pathway of apoptosis. This is the same pathway, extrinsic pathway of apoptosis. Okay. So when we talk about FAS ligand pathway apoptosis, this is very important mechanism of peripheral immune tolerance. Okay. So that is why if suppose FAS gene is mutated, if the FAS gene is mutated, then what happens? It causes a disease called as, it again causes an autoimmune disease called as ALPS. Okay, so what is ALPS? Again keep thinking, next question. Okay, so ALPS is the disease caused by FAS mutation. Okay, this is autoimmune lymphoproliferative syndrome. Okay, so energy. So energy, you already know, when you don't receive the second signal, the T cells go for energy. So for T cell activation, we require two signals, first signal and second signal. So I'm not going to tell you this in detail. I have already explained this in detail on my video on immunodeficiency disorders. Okay, so I have already explained it. So just in short, I'll just tell you. So normally you require two signals for T cell activation, signal 1 and signal 2. So if you don't receive signal 2, T cells will not get activated, they will become silenced. So this procedure is called as energy, and it is a mechanism of peripheral immune tolerance. Okay, and here we have a very important molecule that I have already explained to you in a detailed video before, CTLA4, which is very important molecule in silencing. So if there is a mutation in CTLA4, this also will cause autoimmune disorders. So mutation of CTLA4 will not let energy happen, not let silencing happen, and it will cause autoimmune diseases. Okay, so remember, three mechanisms of peripheral tolerance, and all three are associated with diseases. IPEX is with FOXP3, ALPS is with FOX gene, and CTLA4 is with other autoimmune diseases. Okay, and one more I would like to tell you here. So what is central tolerance is basically done by IR gene. So there is another molecule called as PTPN22. This you should know, my dear friends, that PTPN22 is the most common gene associated with autoimmunity. Most common gene associated with autoimmunity is PTPN22, and it affects various parts, but typically it also prevents negative selection. So it does not allow negative selection to occur properly. So what happens is self-reactive T cells can escape. This is typically associated with rheumatoid arthritis. So this is one of the very common gene associated with rheumatoid arthritis, and this is a PTPN22 gene. Okay, most common gene associated with autoimmunity. Okay. Now, so I told you I'll ask you a next question on IPEX. Yes, so answer this. Not true about IPEX. It's an immunodeficiency disease. It is a mutation of FAST gene. It is an X-linked disorder, and it causes polyendocrinopathy. Quick. What is the answer? I hope you know this. We have already discussed mutation of FAST gene causes ALPS. It does not causes IPEX. It does not causes IPEX. So quickly, let's see these full forms which we should know. Okay. So when we talk about this, so you know what is IPEX? IPEX stands for I for immune dysregulation. I for immune dysregulation. P for polyendocrinopathy, E for entropathy, and it's an X-linked disorder. So X-linked disorder, entropathy, polyendocrinopathy, and immune dysregulation. Whereas IR, we have already talked autoimmune polyendocrinopathy. FAST gene causes autoimmune lymphoproliferative syndrome. Autoimmune lymphoproliferative syndrome. So see here, the options that were given to you were, it is immunodeficiency, yes, I for immunodeficiency, P for polyendocrinopathy, E for entropathy, and it is an X-linked disorder. So all are correct. Clear? Okay, so let's quickly go to the next question. Okay, so Darwin's law of survival, survival of fittest matches with which of the properties of the tumor? Tumor evolution, tumor growth, tumor resistance, tumor resolution. So Darwin's theory correlates with which of these? Tumor evolution, tumor growth, tumor resistance, tumor resolution. So what is it? What was Darwin's theory? Darwin's theory was that only the fittest will survive. So to survive, to become fit, you have to acquire new mutations. So let me show you the Darwin Finches, what Darwin draw. So this is the Darwin's Finches. So what did Darwin said? See, he has also written I think. So you can see this is Darwin's Finches. He's written something, scribbled something. So Darwin said that any person starts as person 1, and with time he will acquire new mutations and will either change into B, C or D. Okay, and those which will not acquire any mutation, they will collapse. So only those who acquire mutation, they become fit for survival. Okay, so this is the theory of evolution. So tumor evolution also follows Darwin hypothesis. Remember here the two concepts which you should remember. There are two types of mutations, driver mutations and passenger mutations. Driver means driver is like driver. Okay, so who sits in the car and starts the car? Who is this driver? Who sits in the bus and starts the bus is a driver. And then after some time, who started the car? Driver. After some time, more and more he'll ask all the passengers to come in. Okay, so obviously if I am talking about a truck or a car or a bus, more the number of passengers, more the advantage, more the profits, isn't it? So same thing here. So there is always a first mutation. So this is a normal cell. So first mutation when happens, and this starts the cancer. What is this mutation called as? Driver mutation. Okay, so all of you must have seen so many cases of breast cancer, isn't it? So do all the breast cancer patients behave similarly? No, they don't behave similarly, isn't it? All of them behave differently. Okay, some of them you will see that they will survive for 10 years and nothing happens to them, and some of them will collapse even in 6 months. So why this happens? Okay, this happens because of passenger mutations. Okay, so if we say the initiator driver mutation was same, still one died in 10 years and the other died in 6 months. Why this can happen? Because of passenger mutation. So that cancer which acquires more number of passenger mutation will progress very fast, will evolve very fast, whereas those cancer which will not acquire any mutation will not progress very fast. So I'll give you another example. CML, everybody knows, has a chronic phase, accelerated phase and blastic phase, isn't it? So one of the very important criteria of accelerated phase is new mutation. So once new mutation, so Philadelphia chromosome, everybody know, okay, 922 translocation, everybody know is present in CML. But if some new mutation occurs, that means that this person is now in accelerated phase. So remember, in CML, any new mutation will put the patient in which phase? Accelerated phase. So what is this? Tumor evolution. So tumor evolution follows Darwin's hypothesis. Okay. Whereas there is one more curve which you should know, tumor growth curve. So tumor growth is given by Gompertzian growth curve. Okay, tumor growth is given by Gompertzian growth curve. So understand this also. So see, the tumor is growing very rapidly in the body. So when do you diagnose it? By the time you diagnose it, the cancer cells have already reached 10⁻⁹. So the cancer cells will reach 10⁻⁹ and then only you will detect it. Why? Why so late? Because this is the time when the mass will appear. Okay, obviously how do you pick up lymphomas? When there is a lump. Okay, how do you pick up breast cancer? When there is a lump. So when the lump appear, that means the tumor cells have become 10⁻⁹. That is 1 gram of tumor. So this is the current threshold for diagnosis of the cancer. This is the current threshold for the diagnosis of the cancer, 1 gram. It's very late. Why? Because during this phase, cancer cells has already completed this life cycle and they are already reached the resting stage. So whatever chemotherapy you give, whatever radiotherapy you give, patient is not going to improve. Patient is not going to improve. You understand that? So that is a very important implication that you have to understand. Okay. So now that means that has laid the way for liquid biopsy. That is, you have to pick up the tumor cells when they are in circulation itself. So whatever material they are shedding, DNA and protein, just catch them, analyze them and diagnose it. That's liquid biopsy. But today's time, we are on a very good pathway of liquid biopsy, but still at many places, the current threshold for diagnosis of the cancer is 10⁻⁹ cells. So this curve shows you tumor growth. And by the time the tumor cells become 10⁻⁴, the person will die. Okay, so this is Gompertzian growth curve. Okay, so read the question again. So what Darwin's law of survival fits with? Tumor evolution. Tumor growth is with Gompertzian growth curve. Okay, so tumor resistance and resolution doesn't have any curves associated. Okay. So this is the second last question of the day. Okay, so quickly, what is not true about VHL gene? Which is not true about VHL gene. What is VHL? Von Hippel-Lindau gene. Okay, so first there are so many tough things given here. So first let's understand what is a VHL gene. So remember always, VHL gene is a tumor suppressor gene. It is a tumor suppressor gene. So let's understand. Whenever we get hypoxia in our body, our body immediately induces a molecule called as HIF-1 alpha. Our body induces a molecule called as hypoxia inducible factor 1 alpha. So what is the advantage of this factor? This HIF-1 alpha will immediately go to the nucleus and it will start inducing VEGF. Okay, because what does our body thinks? Our body thinks that the most common cause of hypoxia in our body, what do we think was? Ischemia. So immediately our body starts inducing VEGF so that ischemia can be improved. So this VEGF starts producing new blood vessels, and after some time what will happen? The oxygen levels will become normal. Now when the oxygen levels become normal, then our body induces a gene called as VHL gene. Then our body induces a gene called VHL gene. So this VHL gene, what will it do? It will go and block HIF1 alpha. This gene will go and block HIF1 alpha. So this HIF1 alpha will be deleted. But remember, when is VHL produced? Whenever the oxygen levels are normal. So what will happen when HIF1 alpha will be gone? This will stop VEGF and vessel formation will stop. You understand that? That's the pathway of VHL. So this is a tumor suppressor gene which does not lets excessive angiogenesis to occur. Does not lets excess angiogenesis to occur. So that's VHL. Now suppose if VHL gets deleted, then what will happen? Obviously, there will be nobody to control angiogenesis now. So there will be lot of angiogenesis going on. So this will go and promote the development of lots and lots of cancers. So most common cancer to occur by deletion of VHL is hemangioblastoma. So if you see, what is hemangioblastoma? Hemangioblastoma is a tumor of cerebellum. It is a tumor that occurs in the cerebellum. And if you have seen my video on CNS, you would have seen that hemangioblastoma is a tumor which has lot of vascularity. Okay, it's lots of proliferating vessels in them. That is why hemangioblastoma. Okay, so this is a cerebellum tumor and it occurs whenever there is a deletion of VHL. You understand? Please remember, blood vessel tumors does not occur because of VHL tumor. It does not cause endothelial tumors. Okay, so it just causes increased vascularity in the tumors. All those tumors which have VHL deletion usually have lot of vascularity. Why? I hope you understand, because VEGF is more, so more proliferation of the vessels. So hemangioblastoma is the most common tumor which occurs by deletion of VHL gene. It occurs in the cerebellum. Okay. The second tumor that occurs due to deletion of VHL is, I hope you know this, renal cell carcinoma. Which type? Clear cell type. So clear cell type of renal cell carcinoma is the second cancer which occurs because of VHL deletion. Again, you remember, so they have clear cells, but they have lot of proliferating vessels in between them also, which you can see. Again, third is pheochromocytoma. Now this is very, very important. Again, it has lot of vascularity. In fact, it shows Zell-Ballen pattern. Okay, so that's very typical of pheochromocytoma, which also occurs by deletion of VHL gene. Look at the next tumor, endolymphatic sac tumor. Endolymphatic sac tumor. So this is a tumor of the ear, endolymphatic sac tumor, which can occur. And then there are a lot of liver cyst and pancreatic cyst. All those also occur by VHL deletions. So remember, most common tumor is hemangioblastoma. Is everybody clear with the pathogenesis? So now let's come to this, which is true. They are asking which is true. Okay, true about VHL gene. So it binds to HIF1 alpha in normal oxygenic state. Does it bind in normal oxygenic state or hypoxia? Normal oxygenic state. So this is true. In the absence of, so this should be, so in the absence of VEGF, HIF1 translocates to the nucleus and activates the transcription of genes such as VEGF. No, not in the absence of VEGF. In the absence of oxygen, HIF1 translocates to the nucleus and activates VEGF. Then it would have been correct. So this option is not correct. It is a protoncogene? No. It is a tumor suppressor gene. It's not a protoncogene. Germline mutations of VHL are associated with hemangioendothelioma. No, it does not cause vascular tumors. It just increases the vascularity in tumors. So hemangioendothelioma is a vascular tumor, not associated with VHL gene. So the answer is A. How many of you marked correct? So give 1 point if you mark this question correct, and -1 if not correct. And do message me your scores after the end, because for now everywhere the live session is going in YouTube and in Facebook, everywhere. So I'll see all the answers. So you know I'm very good at it, going through everything. So I'll go through all your comments and I'll see who is the winner. Okay. Okay. So this is the last question of the day. Okay. Okay. So let's see how many of you answer this. Hypotrichosis is seen with desmoglein 1, desmoglein 2, desmoglein 3, desmoglein 4. Yes, what's the answer? If you know, it's a spot question. If you don't know, then it will be A, B, C, D or Ina, Mina, D, Ka, mark that. So what is it? Hypotrichosis is seen with mutation in 1, 2, 3, 4. So do you know what is desmoglein? Have you remember? Again, I hope if you have remembered my video on cell interactions, you would be very clear with it. So if you're not seen, please see it. Okay, it's in YouTube page. It's also on my app. Okay, please go through this. Okay, what happens in it? You know, cell to cell interaction. Okay, two cells can join to each other either by spot desmosome or belt desmosome. So desmoglein is a type of spot desmosome. Okay, whereas belt desmosome is ecadherent. So whenever there is some problem in the spot desmosome, and if it is broken, so these cells lose connection with each other. So that leads a space and it can form a bulla. It can form a bulla. So when we talk about skin, okay, skin, the lower part of the skin, okay, lower part of the epidermal cells are joined to each other by desmoglein 3. Whereas the upper part of the skin are joined, epidermal cells are joined to each other by desmoglein 1. Okay, whereas hair contains desmoglein 4. Okay, so hair contains desmoglein 4, and heart contains desmoglein 2. Heart contains desmoglein 2, and there are only 4 types of desmogleins, so you don't need to worry about more. So there are 4 types of desmoglein: 1, 2, 3, 4. So if you know all these 4, you're clear with it. So 1 is upper part of the skin, 3 is lower part of the skin, 2 is heart, and 4 is your hair. So obviously, if you know this, your answer is done. Okay, so hypotrichosis is seen with, you don't even need to know more. Who is present in hair? Desmoglein 4. So desmoglein 4 will cause hypo. So remember, everybody knows about hypertrichosis, which is a Y-linked disorder. Okay, what is hypotrichosis? That is when the hair are very sparse, fragile, sparse hair. That's hypotrichosis, and it occurs due to mutation of desmoglein 4. Okay. Now, again, if there was a question which was asked in JIPMER this time, I think JIPMER or AIMS, I think, and I don't remember exactly, but it came in the recent exam. That is ARVC. What is ARVC? Arrhythmogenic right ventricular cardiomyopathy. What happens in this? The right name itself says it's a right ventricular cardiomyopathy. So it's very typical. What happens in this? The right ventricular wall, okay, is completely replaced by fat. It's completely replaced by fat. So as soon as the blood comes, it's a very flappy, because there's fat, obviously there's no muscle. So what happens? The person starts getting erythemia. So you know which desmoglein is very important for binding the muscles of the heart together? Desmoglein 2. Okay, so when this is not there, the muscle do not attach to each other well, and that is why fat comes and infiltrates between it, and that is why the patient get ARVC. So typically, patients with ARVC gets mutation. ARVC gets mutation of desmoglein 2. Okay, so desmoglein 2 causes ARVC. So desmoglein, if you remember again my video, desmoglein and desmocolins, both are spot desmosome. So desmoglein 2 and desmocolin 2 both can be mutated in ARVC. Plakoglobin is a part of it. So these are desmoglein 2 which is mutated in ARVC. Okay. So there is a syndrome also associated with it called Naxos syndrome, which has plakoglobin mutations and all that. So that is heart questions. So when I do some quiz on heart, then I'll put questions on it. So desmoglein 2 is ARVC. Okay. So about desmoglein 3, all of you know desmoglein 3 mutations typically occurs in pemphigus vulgaris. Pemphigus vulgaris is a bullous lesion of the skin, and typically has typically antibodies are formed against desmoglein 3. So what happens is the patient gets suprabasal bulla, whereas desmoglein 1, so pemphigus vulgaris can also have desmoglein 1 mutation, but desmoglein 3 is much more common than desmoglein 1. So in desmoglein 1, pemphigus foliaceus is more common. Okay, so pemphigus foliaceus. Okay, so I'll write it here. Pemphigus, okay, foliaceus is more common. Okay, pemphigus foliaceus is a bullous lesion which is more common with desmoglein 1 mutation. Okay, that is this. Okay, so that is what you should know. So with that, let's finish the quiz questions today. I hope you've done good. Okay, do let me how you like the live session, because this is the first time I'm doing the live quiz. So do let me know if you like or not. Okay, so if you like it, definitely let me know so that we can have more sessions like this in future. And tell me how were the questions, and of course tell me your scores. I'll give you a prize, of course. Okay, let me know how have you done. Okay, bye bye.